Dr. May and Dr. Hosna, for this nice introduction. It's my pleasure to be here today. So hopefully we'll learn something about cardiac PET and indications. And please, if you have any questions, let me know during the session or at the end of the session, and we'll go from here. So I think I like the topic about the role of cardiac PET from myocardial perfusion imaging and myocardial blood flow, because there are a lot of changes in cardiac PET in the last 15 years. And these are my disclosures. And I'm a biased imager, but also I have a lot of other non-medicine and cardiology stuff that we do in our life. And if you watch soccer today, my team United, Manchester United, had won the game, so it was a great game. So that's usually a good thing in the weekend when our team win. So this is our agenda, right? What we need to establish a cardiac PET program, and I know that can be a little bit challenging in Africa and the Middle East and some place in Europe, and believe it or not, in the US as well. So we do have cardiac PET available, but not in every state, not in every institution, because they have a clinical application in coronary artery disease and beyond, and there is a lot of development on that. We'll try to understand a little bit about cardiac PET, and we came up with this platform, and I think all these papers available for scanning, if you use a QR code, because we have a lot of variation between Latin America and Europe and the Middle East, and I think some places may have more PET than others, and other people may have cyclotrons more others, and maybe other places they don't have both of them. And I think we came across that we are not the same where we approach cardiac PET in the US with our colleagues and partners outside the US. And when we think about cardiac PET, right, and I think as any PET CT, right, we have a hardware, we have tracers, we have softwares, and you guys all the expert in this. And this is from our ASNE guidelines back in 2016, and this is under development right now, and it will be updated soon. So, and we all know cardiac PET have a superior imaging quality because we have an annihilation event when we have the photon have an annihilation event with high energy with 511 keV. And we pick that on detectors, and these detectors will display later on the nice images. And just so you know, I'm playing with AI these days. I'm trying to get a little bit how we can project that, but it's not really necessarily the same that we do, but we have a nice detection with high energy, and we image the heart with the tracers, right? And we then process these images in the software. And depending on your system, right, is it a PET CT or an older version dedicated PET without a CT? And this is important to understand the difference because a lot of things going to be coming up down the road when you analyze these images and process it. And it's a little bit different when you think about the difference between PET and SPECT, because in SPECT, the single photon create the image creation, but in PET, we have two photons, and that result with high energy and high spatial resolution as well. The camera is different because in cardiac SPECT or in maybe cases, camera focus with a colorimeter. In PET, we don't have a colorimeter, we have detectors, right? And then when it comes also for cardiac PET, because we are having high energy, we need to deal with the high energy and attenuate all of these scattered images and photon and how we do with that. And that's have to have attenuation correction. And this is have to happen. It's simple and necessary depending on your system and how we do that, right? And we'll talk a little bit about that. So higher diagnostic, higher image quality, and then we need to do some sort of attenuation. And in SPECT, basically we do stress tests, and in PET we have other tracers like FDG and F18 product and so on. So and depending on your system, and regardless if you have a 2D or 3D CT or without CT, your image quality going to be superior and excellent. And that's kind of like one of the major advantages of cardiac PET when we compare it to SPECT, because really the quality of cardiac PET, what moves the needle, and that will evolve in our guidelines. And we think a little bit about why it's important to adapt cardiac PET. So in short, we acquire acquisition in the scout images, and then we have a transmission with the CT, if you have a PET CT. Um, uh, and then after that, to create a map, and that map going to be um, allocated with your emission images, and then you're going to have transmission emission images, and then you created the pictures. But when we do that, we have to be careful that we have a little bit of gating, right? We have to acquire the images with the heart is moving, is beating, like a cardiac CT, like a cardiac MRI. We have account for the gating, because if we have good gating and respect the R to R interval in the EKG, as you can see here, we're going to have a good image quality, and we can have an accurate ejection fraction and accurate volume. And also we can pick wall motion abnormalities, and as long as we follow, the tracer follow the chamber, as we can see here, as a transition from chamber from the right side to the left side, from right atrium to right ventricle, left atrium, left ventricle. I think we care a lot about the left ventricular myocardium and left ventricular cavity. And because at the end of the day, after we display the images and the gating, we can measure in our dynamic images cardiac PET myocardial flow. And basically, again, as we cared a lot about the myocardium, we can really know which area have the highest blood flow, and then calculate what we call the myocardial blood flow reserve. We can calculate peak stress myocardial blood flow, and so on. So all of this information can come from one um, um, imaging modality, which is a cardiac PET. Now, depending on your system, it could be new, it could be refurbished, it could be really fancy and up to the last model, or it can be a little bit older version. And I think when you acquire or think a little bit about building a cardiac PET program, either one of them should do, but you have to understand your system, because depending on that, you're going to build your lab, you're going to have your quality checks and all of these things. When we add CT scan to the cardiac PET, we cover the attenuation correction. But attenuation correction does not only happen with CT, can happen also with a dedicated cardiac uh, PET without a CT, with something we call it line source. And we're going to see an example for that. But adding the CT itself is not just going to help us for attenuation correction. We can look into the anatomy of the different structures. We can look into the coronary arteries. We can see if you have a calcium or no calcium. And we need a little bit of slices. We need at least minimum 4. I think the lowest one I worked on was 16, and that was okay to give us a visual qualitative, just mild, moderate to severe coronary calcification, and that is important. Now, when we think a little bit about dedicated cardiac PET without a CT, we have what we call it line source, and that help with the attenuation, and that will give us good image quality if you compare no attenuation correction on the bottom and attenuation correction. And the same quality, believe it or not, gonna be with the CT, but the CT will have a little bit of higher quality, because you see anatomy, you create maps and all of the above, right? And it's still going to have high quality images. And we have a lot of centers who are doing cardiac PET without CT, and they have great turnaround and they have great image quality. So I think understanding that attenuation correction and how you do it in your scanner will help when we think a little bit about understanding artifacts or not. And I think this is just for comparison, how the difference between cost and advantage and disadvantage with dedicated PET and PET CT. And I think we came up with this nice algorithm with artifacts, right? When, as I said before, you have an emission, you have transmission, and the patient in the scanner. And if the patient move, you're going to have some sort of interscan motion artifact. You may have missed registration artifact. And I think if you think a little bit about these cases between on the top stress and rest at the bottom, right? And you think a little bit about this case here, you have, if by comparison, you have a large reversible defect in the anterior wall, But I think if you go back and see into your transmission images, your boundaries are really the heart and the chest, and I think you need to adjust that, right? And I think maybe you try processing it, maybe if you have a good registration between emission and transmission, that's before you reconstruct the images, that can help a little bit. But sometimes these misregistration artifacts can be a little bit difficult, and I think sometimes we need to repeat the scan. The other artifact, the motion, right? The breathing artifact, the patient moves too much and moves really in all the direction, and you can see here, are we calling this an anterior defect, an inferior defect between when we compare their stress and rest? And again, if we educate the patient a little bit and try to minimize this motion, we will minimize the artifact. Obviously, adding the CT will add a layer of more artifacts can happen, but also you have scan-related artifacts, and you have also patient-related artifacts. And understanding that will help a little bit when you look into your artifacts, and that can really apply for a lot of the PET-CT or a dedicated PET as well. And all this QR code will have videos with Dr. James Case from ASNIC have a great outline of that, and I think that can be very educational as well for the other artifacts as well. Now, as we move into the era of cardiac PET, right? And I think recently we know there's a lot of development in cardiac PET, and we have FDG, and recently we have really the new kid in the block, which is flurpiridaz, the most recent tracer in cardiac PET for stress test. And I think historically we said, okay, how we can do a stress test on cardiac PET, right? Historically, we do rubidium. If you have, and this doesn't need a cyclotron, it's like dose related. You need a generator with all these characteristics that you guys more expert than me in it. And then if you have a cyclotron and if nearby, you can handle it with ammonia. And then the new tracer with flurpiridaz. For the last maybe 25 years, we finally have a new tracer that really we think can move the needle in terms of application and clinical application. And why is that? Because it just have high image quality, as you can see with the characteristics. But I like this slide because it's telling us F18 flurpiridaz is not just have one of the highest myocardial extraction because it binds to the myocardial complex, and it will lead to high myocardial avidity, and we don't need a cyclotron. But also we're going to have image quality, which is superior. Okay, what else? Spatial resolution, great. But also I can put the patient and exercise in the cardiac PET. And I think for the first time, we can put a patient on the treadmill and do cardiac PET now can be available with flurpiridaz. So I think this is very important concept. And I think for the physicist in the room, I think right, the minimal rule of phenomena, which is important because that means it just will be contained within the myocardium when you look into the line activity curves and all of that. So it is a superior tracer and really crafted for the heart, right? However, this is kind of like if you compare system SPECT images and you try to look at the PET with the flurpiridaz with a normal patient and abnormal patient, and you can see how the images are crisp. When you look into these images, we pick a little bit of RV intake. Sometimes the apex can be a little bit thinned, and usually that's normal in the flurpiridaz and really cardiac PET as well. But when we see abnormal cases, right, we pick it very good and with very high accuracy and very good image quality. And I think this is just an image of a patient with flurpiridaz. However, flurpiridaz is not just one of few tracer we do. I think the workforce for cardiac PET is rubidium, right, as a tracer. And then depending where you are, I think we're still in the US adapting the flurpiridaz, and still few centers are using it. And then still a lot of centers use ammonia. But when you stress your patient in the cardiac PET, you can use for a lot of the stress agent, right? Either you adenosine or dobutamine in some cases. So depending on your facility, what's your tracer availability, what's your stress agent available, and I think this is have to be variable between different institutions. So why cardiac PET? Again, because we think a little bit of unrevealed accuracy, superior efficiency, low radiation, unique information, as we're going to see with the left ventricular ejection fraction, which is how the heart push, how the pump of the heart work. We can measure the reserve of the ejection fraction. We can put an eye on anatomy if you have a CT scan with the coronary calcium score and myocardial blood flow. And then application beyond coronary artery disease. However, we're going to be focusing today on coronary artery disease. Unrevealed accuracy, because we know it can be routine and robust and fast. I think depending on your tracer, I think we should maybe update these tracers. And I think for the resolution, it's highest going to be with the ammonia and oxygen, obviously, but I think fluoroperidaz is going to be very close. And believe it or not, the majority of us here in the US, we use rubidium. And I think when we do that, and this is very interesting because we, especially with the rubidium, we measure the ejection fraction or everything in the myocardium at peak stress. And this is very fundamental advantage of cardiac PET because anything we do and extract from the cardiac PET is going to be at peak stress. So at peak ejection fraction, at peak myocardial blood flow, and that is important. And this is why when we think a little bit about superior sensitivity and superior specificity, because of all these reasons that we think a little bit about, and that's what's shown in a lot of trials as well. And we can see if you think a little bit about the kinetics of the tracer, fluoroperidaz really higher than technetium, rubidium, that's really the workforce for SPECT and PET, but also even more than the ammonia and obviously below oxygen. But I think this is important that we are advancing our tracers and we're getting closer to the oxygen, which is, I think, a good um, advantage for nuclear cardiology. Now, this is a very famous trial with called the Pacific trial, where they try to look into all these imaging tools between SPECT, PET, coronary CT, and you can see how cardiac PET has really one of the highest diagnostic accuracy when they compare all of these to invasive FFR. There's like 200 patients head to head, they diagnose all of that together, but I think when we look into that, cardiac PET have the highest diagnostic accuracy, 85% than SPECT, obviously, and coronary CT. Maybe this number is going to change now because coronary CTA have a lot of advantages and the scanners become better and the quality become higher. However, cardiac PET usually stands still in that area. Diagnostic accuracy, cardiac PET still superior. And then I think it's very important because we don't have a lot of trade-off into sensitivity and specificity if you compare it to a SPECT or other modality as well. Now, superior efficiency, because this is your protocol. 23 minutes maximum, top 30 minutes, everything is done. We get your topogram, we get the attenuation map, you get your tracer injected by your rubidium or any tracer you want. 7-minute acquisition, you have a rest. You inject with regadizine, and then after that, you acquire your stress test, and the same tracer usually sometimes can be higher depending on your weight, and then you acquire your peak stress, and then you have your perfusion maps and you compare the stress and rest, and we are done. So basically, your template in the day can take up to 10 to 12 cases of PET because really it's just patient in, patient out, and that's important. If you are running a busy lab or even starting a program, right, it's important to have a short protocol that give us the answers and move on. A little bit, this protocol can be a little bit longer with fluoroperidaz because the acquisition can take some time and the injection and all of these things. So I think that's important when we think what trace are we using and will mandate what's my lab efficiency, right? Radiation. I talk a lot about CT. If you add a CT to the PET, that's going to increase radiation. I don't think so because we did look into that. With all the PET protocol, as you can see, it's going to be still lower than your SPECT thallium or technetium. And even if you have a CT or not, if you give FDG or rubidium, regardless. So all of that gonna be important to understand that we are not giving higher radiation with the cardiac PET. And then unique information till we all agree everything looks great. So what else we can get from the cardiac PET? I think number one, I think we talk a little bit about you measure your resting ejection fraction, you peak ejection fraction. If the difference more than 5, that's great. That means we have a high negative predictive value to exclude left main or three vessel disease. So we compare not just the myocardial perfusion images, what we call it relative perfusion imaging at rest and stress, and also the quantitative value we get from the cardiac PET between rest and stress. Number one with ejection fraction, and then next we're going to learn about myocardial blood flow. And myocardial blood flow, as we think a little bit about blood flow in the coronaries in the large epicardial blood vessel and also the microcirculation. And when we think a little bit about an imaging modality that gave us all this information that can give us all the flow data in one blood vessel, I think we have to know how we are imaging and how we acquire the images. I think we all think that if we did a coronary CTA, we will be really limited into this area. When we think a little bit in the small blood vessel, we can exclude macrocirculation with coronary CTA, but there's a lot of things happening downstream. And I think this is why we like to get a perfusion testing or a functional testing that we can image and acquire. I think historically we used to do dobutamine echo, but we can get blood flow with dobutamine, but it's not really that accurate if you compare it to cardiac MRI and cardiac PET. But I think they're really more robust with all of this and practically and clinically available as cardiac PET, because we can not just detect the blood flow in single area, but we see it in the entire blood stream to differentiate between is it focal stenosis, is diffuse atherosclerosis, or microvascular disease. And I think knowing the myocardial blood flow and the other metrics in the cardiac PET will help us that. So depending on your software, the number is going to come to you, depending on if you're using all really modern software can give you myocardial blood flow data and give you maps and all of these things. And basically we measure the blood flow at peak and rest, and we divide them, and we're going to have a reserve. And that is important because once we have that reserve, we can understand where our patient going to be. And I think this is a little bit busy slide, but I think a little bit about we put the patient depending on the myocardial blood flow reserve and the maximal blood flow or peak blood flow at peak stress. In which category? Are the patient is happy and everything is great if you compare the myocardial blood flow with the perfusion imaging, in which we call it concordant, and that's normal. This is a happy area. Or everything is abnormal and we call it concordant but positive, and that means concordant impairment between the myocardial blood flow and the reserve. That means everything is abnormal, and this is high risk patient. And then the other category that when we put the patient here, depending on what discordant you are looking, you may say normal blood, normal myocardial blood perfusion or imaging when you look at it, but the blood flow is abnormal. And what that means, I think we know and study this population, and we know they have intermediate risk. But also, when you have a little bit other patient, when you have a preserved myocardial blood flow and you have abnormal myocardial perfusion imaging, maybe they have a little bit lower risk. And I think regardless how you put patients here and there, I think adding the myocardial blood flow to your relative perfusion imaging can help us to stratify and um, 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 uh, categorize our patient to high risk, intermediate risk, and low risk, or really minimal risk. And I think this is important because our intervention colleagues and people who want to put all these stents and in the cath lab and do coronary angiography and all of that, they like to know what these numbers are, and that can actually guide revascularization strategy down the road, right? And this is really robust data. Over 5 years with more than 4,000 patients. So I think it's very believable, right? And I think when we think a little bit myocardial blood flow, it's not just giving us prognostic value, And think a little bit about, without going into the details, but every zero point 0.1 decrease in your blood flow reserve associated with 9% increase of death hazard, zero point 0.1 unit. And I think this is how the beauty of nuclear cardiology and cardiac PET, and because we can measure everything with high fidelity and accuracy. And also, if we know that, it can guide patient management. I think if we have a reserve less than 1.8, we know that we maybe need to open this blood vessel. We need to make things better. But if it is above, maybe we don't need, because we maybe have collaterals, maybe try medical treatment. But we think very um, uh, positively right now when we use myocardial blood flow. And again, it correlate with ischemia, depending on the myocardial blood flow. If you have ischemia more than 10%, we understand that you're going to have very low myocardial blood flow reserve. So still, it correlate with the flow data with the ischemia that we see on the relative perfusion. So that's expected. The lower, you're going to have more ischemic areas and areas that need to be opened and revascularized. And then, so what the numbers, right? Depending where you're at, I think majority of us use 2 as the normal for myocardial blood flow reserve, and this is a nice guidelines from ASNIC. And then, and we know if it is normal, I think some labs use 1.8 more than 2, but I think in the guidelines, we like it to keep it above 2. Interpretation normal, this patient is low risk. If you have 1.7 to 2, mildly abnormal, not really hot to the patient, it's intermediate risk. If it is really below 1.7 up to 1.2, that's abnormal high risk. And if we did see perfusion defect, that we know that's a very high risk patient. And I think we have to understand also that if we did see low perfusion, no myocardial blood flow data without a perfusion defect, I think this is a message that we have to make sure the numbers correlate and doesn't have technical difficulty or technical abnormality when we blot it with the perfusion. Because the perfusion may be true and the blood flow could be true, but we just need to make sure we are getting the right number. And I think we are not facing a non-responder patient or a patient that does not respond to the stress agent. And then we have a low myocardial blood flow data, but they have normal perfusion and have normal perfusion with no reversible ischemia, and we label them as an abnormal and take them to the cath lab. So I think understanding what are we getting, we have to check the quality control, and that is important when we look into this. Before, we used to say just let's do it in naive patients, no coronary artery disease. Now we do it in all patients across all line. PCI, CABG, MI, renal failure, diabetes, all patient population, we can use myocardial blood flow. And there's a lot of scenarios can happen, as I said before. And I think the value when you put them together is not just you're going to confirm what I see and detect high-risk patient, but also I'm going to make sure I am stressing my patient in the right way. And also I can identify microvascular ischemia and disease. We have a lot of patients who are diabetic. They come to the cardiac pit. They have a normal myocardial perfusion. They have a little bit of coronary calcium, but they have severely reduced myocardial blood flow data and reserve. And basically they have microvascular disease. And the same with the transplant patient or kidney patient and so on. So I think the myocardial blood flow adds a lot to our stress testing in cardiac PET. And there's an emerging application in transplant. I think where the microvascular ischemia is very important in HFpEF, heart failure with preserved ejection fraction. Now with all the thick heart phenotype, hypertrophic cardiomyopathy, amyloidosis, aortic stenosis, all of these things, we're going to see emerging application beyond coronary artery disease. And I think a lot of our patients can have a couple of them, right? If people have coronary artery disease and have bad blood vessels, they may have heart failure, they may have aortic stenosis. So I think we have to understand that concomitant disease can also affect the presence of abnormal myocardial blood flow data. And then second, quantification of coronary calcification. If you have a CT scan with the cardiac PET, I can see the blood vessel nicely. I think this is the aorta, this is the PA, this is the left main, and this is the RCA gonna come here, or the right coronary. So basically we are looking at the blood vessel. I can see here nicely, I don't see, of course, it's not really high quality. I don't think this is a plaque or non-calcified plaque, but I think we try to see anything white. Anything white, we'll call it. You have no calcium to a mild calcium to moderate, maybe severe calcium. And now we can tell the patient you have anatomical evidence of atherosclerosis and coronary calcification. That's uh, one of the advantage of cardiac PET if you have a C. And I think either you do quantification or qualitation. What I mean by that, you look at it or you process it under the software. It really works because we just need to know if the patient have coronary artery disease or not. And it's important because the higher the calcium in this blood vessel, the more ischemia going to be. And it correlates with all outcomes if you use just a coronary artery disease. And it's going to get better if you add the coronary calcium score as well to the myocardial blood flow. And the higher calcium, the lower the flow data, and the high ischemia burden. And basically, what we're trying to do in the cardiac PET, right? It's a multi-parametric evaluation. It's one tool with multiple tools. I don't think we can call it multimodality imaging, but I think it's multi-tool or multi-parametric because the same machine, the same scanner, I get my relative perfusion with MPI. I get my function, ejection fraction. I can see the LV reserve. I can plot the map. I can see how much reversibility, if I have a scar or total ischemia by comparison. And that's what we've been doing in the last really 10, 15 years. And now we added CT scan to the system to now we started to see calcium in the blood vessel and can add to that. And recently the myocardial blood flow reserve, which kind like help us to navigate between the different patient population. Like I like this document from ASNIC as well because there's a lot of cases, right? You can look into the scenarios, you can look into what's happening and what's going on with the patient, and then the authors came up with like a nice readout and you train how to read these cases, right, in a very diverse population and indication. So I think this is really how to use the myocardial blood flow and in clinical practice. Now, when you think a little bit about cardiac PET and coronary artery disease, when we know cardiac PET is superior in a lot of these indications, right? And I know you guys expert in viability, sarcoid, inflammation, infection. And I think when we think a little about coronary artery disease, we think about viability, right? And I think FDG. And I think this is important because FDG, I think this is where different than what we used to, or the stress, rest, and stress, right? We are entering the area of affecting the myocardium metabolism under certain scenarios, right? Usually the myocardium going to uptake the glucose and the metabolism, right? Depending on your uptake in the receptors. And we learned that FDG can act as a glucose with the same enzyme, and we try to make this uptake happen in the myocardium. And when we see that, we can get a lot of information. But really, in coronary artery disease, it's really have to delineate between few disease process, as we're going to see. You tighten your protocol, you manipulate the glucose, you try to reach to the state where there is no uptake in the glucose really by the myocardium, and then you inject the FDG and uptake, right? And I think preparation of this is really important. The fasting process of this is very important. And then we are ready to take the scan for FDG viability testing. And I think this is not an easy process. I think it's important process if you are looking for viability for the myocardium, because we need to know if this myocardium have any hope for revascularization, if this patient going to be important to send them for the cath lab. And this is why, like, I think it's important to consider FDG in coronary artery disease if you want to answer the question. If that abnormality that we see in the myocardium is because of scar, or it is still alive and hibernating or stunned. And I think FDG really is the only modality we like into if you have normal ejection fraction and normal wall motion, normal FDG uptake, and we expect everything going to be normal with the myocardial blood flow. But if you start seeing everything is decreased and gone, and there is no perfusion and blood flow, right? And relative perfusion, that's a fixed defect, right? So no defect, normal, fixed defect, and that is a scar. However, when we think a little bit about stunned myocardium and hypernating myocardium, it is different because stunning usually is an acute process. An acute process will have impact. And I think the most common scenario, if someone came with anterior, like large MI or ST elevation myocardial infarction, acute occlusion of the blood vessel, give them thrombolytics or get a stent and they open the blood vessel, we may have a stunned myocardium and decreased ejection fraction, but we restore the blood flow and we think they have normal perfusion because we did the work, we opened the blood vessel, but the myocardial perfusion on, or at least with the FDG, going to be decreased. And that's label and define stunning. And this is where we see there will be perfusion contraction mismatch. And the opposite of that, hypernation, is a chronic process, right? A patient have a blocked artery for 10, 15, 20 years. Obviously going to decrease the ejection fraction of the heart. That's going to decrease the blood flow. But all these years, the myocardium is starting to open collaterals and maybe have a little bit of other blood vessel to restore viability when we take a little bit increase on the FDG. And this is why with the hypernating myocardium, we're going to have perfusion metabolic or metabolism mismatch because I have mismatch between the metabolism and the perfusion itself. And I think depending on how you look into it, I think no other modality going to give us all of this robust information. And specifically, if you're looking for complex coronary artery disease between rest, stress, and viability. And sometimes we can combine that in the same day, sometimes can have different days, depending on your protocol, because still we think MRI is very robust and have high sensitivity and specificity, but believe it or not, cardiac PET actually have the high sensitivity to pick up viability in the myocardium and very close to the MRI. And I think there's a new publication, this is like back in 2007, but I think there's a lot of publication nowadays that they're going to be very comparable depending on what's available in your lab or in institution. So I think, I would like to go over a case, right, to put all them together, right? And I think this is like a case that came from my lab a few weeks ago. 69-year-old male came with chest pain for 2 months, known coronary artery disease, have calcium score more than 1,000. He did a stress test a couple of years ago, was fine. He got exercise, SPECT was normal. He maybe not that optimal. 77% of maximum predicted heart rate is hypertensive, hyperlipidemia, and good medication. Not that obese, on good medication. So we think this patient is doing okay. Having symptoms, we stress them, and we did not have anything 2 years ago. And usually the warranty for a SPECT, right, 2 to 3 years, but we decided to do a cardiac PET. So I think this is something that we did. So we did see, as you see, stress at the top, rest at the bottom. The rest looks fine, and we didn't see any perfusion defect. And the rest, so no scarring. And then you can see how the stress data, they really diffuse decrease in the perfusion, and specifically more in the septum anterior lateral wall. And kind of like looking in the transverse images here, this is probably an LAD disease. And I think Abuzaid is here, but also the TID ratio, which another thing I did not talk about, which basically visually, if I put my cursor here and I compare it to here, I can see the cavity dilate. And that's really one of the high risk markers when we see that in a stress test. So we say, okay, we have a large reversible perfusion defect, we have a TID, so this patient probably have an LAD disease, but could this patient have multivessel disease? And I think I will argue that TID can be an indication for 3-vessel disease, but also I can see perfusion is really good in the inferior wall, maybe a little bit low here, maybe in the lateral wall decrease. So maybe you have some perfusion defect, right, in the 3 territory. So a few years ago, we said, okay, this patient will go to the cath lab, but now we can look for more data. I have a CT scan, I have a lot of calcium. I know that from the history because you have a calcium score more than 1,000. and the advantage of myocardial blood flow. And I think as rest and stress, and we calculate the reserve value, and when I look at the rest between usually normal 0.6 and 1.2, and I like the number to double, right? And usually at peak stress, I like it above 1.7, 1.8. But if you look here, you're going to see maybe at rest, everything is normal, but at peak stress, everything is abnormal. And when I look at the global reserve, it's really abnormal, right? And I go by each blood vessel, and then we see that the LED, the left circumflex, the right coronary, all of them is low. And now when we report this case, are we dealing with confidence with three vessel disease or not? And I think this is what the report told the provider. This is a high risk scan. You have a large reversible perfusion defect in a patient with severe coronary calcification. You have a transient ischemic dilatation about like 1.3. Your myocardial blood flow reserve is very abnormal in all the territory. This patient is going to have three vessel disease or left main, and that's what happened. There's a coronary angiography. Left main is fine. Distal or proximal, how you call it, distal left main is almost gone. A lot of disease in the LAD, a little of disease in the circumflex, and then the RCA as well, almost subtotal in the mid segment, and this is three vessel disease, and this patient went for a CABG and bypass surgery and doing fine. And really, I did not want to have more conclusion, but I think I like the conclusion to be our latest addition in ASNIC, right, and from our PET working group and PET committee. And when we talk a little bit about what are the clinical indication of PET myocardial perfusion imaging and myocardial blood flow quantification, and this is still pre-proof, not yet published, but I think kind of like being part of the work group in here, I think there's a lot of teaching points and changes here and how we think there, right? If you think about the American guidelines, right, the 2021, 2023, we know stress PET is useful for the diagnosis in ischemia in an intermediate high-risk patient with a stable or acute chest pain as a class 1. Anything else come as a 2A. But the European guidelines really put PET on the top of things. In the intermediate high risk is a preferred modality for over-SPECT. In patient with select PET, if you have a CT, you can measure coronary calcium score. And also it identify high-risk patients. So they put cardiac PET as class 1 in a lot of other indications. And this is what we thought about, right? And what we've been talking about all our courses and lectures and really guidelines. It has the highest diagnostic accuracy. It has it can help us with risk stratification. It's fast, it's reproducible. We can quantify myocardial blood flow. And I think I like this terminology that we can do cardiac PET universal in all patients. And there is no contraindication to cardiac PET, regardless how you look into it. And I think, it's feasible in all patients, regardless race, sex, high calcium score, low calcium score, rhythm, arrhythmia, devices. And I think it trumps and takes above the SPECT and other modality, right? That we have a little bit limitation if you're talking about coronary CT or cardiac MRI, and each modality has a value, but we feel like the value of cardiac PET, when you integrate all of these things, you're going to have a good test for the patient with high quality as well and low radiation. So I think that's kind of like the fast forward for what we think cardiac PET going to be and the recent guidelines and statement papers. And I think I will stop here and happy to take any questions.
Thank you very much, Dr. Sami, for this excellent presentation and for sharing your experience with us. And now we will move to the questions. Please write your questions.
Thank you, Sami, for the very illustrative and very good lecture, which covered all aspects of application of PET-CT in myocardial application. Especially, you showed to us how its value in ischemic heart disease and its quantification, as well as application of PET in viability study. Thank you.
Okay, now we will start the questions. So please write your questions in the chat box or raise your hand if the option of raise the hand if you would like to ask your question directly. We have already questions in the chat box from Dr. Muhammad Abdelrazak. How does residual cardiac activity correction in fluoropyridase study influence the accuracy of the myocardial blood flow?
Yeah, it will affect. I think a little bit about if you have a high extraction, right? We think you will not have a spillover phenomena and all of these things, but in reality, um, there's some affection in the myocardial blood flow reserve data in the fluoropyridase specifically. Specifically, when you think about rest and stress, I think this is why the protocol have to be a little bit expanded and longer than the rupidium to manipulate that a little bit. Yeah, and I did not include the flow data on fluoropyridase because we still understanding there's going to be a lot of publication coming about that. But at least we can say, in general, fluoropyridase stress and flow reserve data is higher with fluoropyridase than the rupidium. That's number one. Number two, we don't know what's normal when we do exercise. So still we need to understand more with the exercise, but you're going to have to be careful when you manipulate your software and try to calculate the flow data with the fluoropyridase. So good question.
Another question from Dr. Shayma. How much does the fluoropyridase cost in USA?
Very expensive. I think it's a big dose, right? So I think depending on your insurance and how volume and all of that, but sometimes it can exceed more than $2,000, $2,000 to $3,000. I think it's a little bit expensive, especially it's per dose. So the dose can be very expensive. So if you're going to give usually 2 to 4 doses, it's going to be very expensive. And we are learning a lot of that because I think this is one of the barriers, the cost. And I know obviously fluoropyridase by GE, right? And they are working into having a little bit better module and reimbursement and payment models, right? In the US and Canada, and I think I know in the Middle East as well. So I think we still in the era to learn more about it, but it's still expensive in the US. So regardless what I say, it's expensive. So
okay, we have another question. What challenges and difficulties are there to establish PET lab for reliable quantitation of myocardial blood flow?
yeah, I think usually it is not that hard to start having a quantification in imaging across board, right? If you think about quantification in imaging, in cardiac imaging, or really any radiology, I think it will depend on what's your technologist want to do and what the technologist expertise, how much we invest in our infrastructure in the lab, but also what software we use, right? Let's be honest, if you have an outdated software, you will not get the updated information. But if you have an updated software, then you're going to have a lot of information that you can start quantify in a lot of things. But when you talk about myocardial blood flow reserve and myocardial blood flow data, there's really 2 or 3 software that make it easy for all the readers, right? And I think adapting that extra software will help. If, for example, if you're using Cedars or Siemens platform, they have a myocardial blood flow. I think there's other vendors that commercial that usually help with that. So I think having a software that can run the numbers and the quality checks as well, because these software are going to be very reproducible when you do the next patient and even the same patient down the road. So it's not that hard. I think you just need to know how to deal with the software, where you put your ROI and try to have the check mark. And I think most of the softwares, when you analyze them, they're gonna give you like green light, green light, green light, or everything is fine, then it process fine, and the time curves and all of that. And I did not go deep on the curves and all of these things, just but the software. I think your answer is the software, and also you have to find, like, if you're gonna go for a quantitative lab, you have to do the right steps for the study, right? If you do a cardiac PET and you're gonna stress and you measure blood flow, you want to make sure the patient did not drink coffee for at least 12 hours. In the guidelines, we say 12 to 24 hours. 24 hours is the ideal, but reality, we can accept it up to 12 hours. We know we may not have the right patient population that always know what they are doing, or still drinking coffee, eating chocolate, having any caffeinated beverage. So I think follow that will be important, at least 12 hours of the stress, educating the patient about the motion and the breathing, so you can have a high quality test. And also kind of like, will help you to have a good test, so we start quantifying. And also, when you quantify the numbers and put it in the report or screenshot and give it to the physician to read it, I think there is another phase, that what we're going to do with all of this data, how we're going to read that and integrate it in our imaging and our report, right? And that takes some time. So I think, at the beginning, right, I think invest with the tech, invest with the person who process, and invest in champion that with one or two people who really take that to the next level, and then with a good software, and then build on that.
Dr. Tariq asks, in fluoropyridase, is a MBFR is a true calculation or extrapolated?
True calculation.
Okay, another question. Does MBF in your talk was meant to refer to global or segmental blood flow? And do we need also to establish an on-site normal limits?
Yeah, so you don't need on-site to have normal limits, but I think now we started to look into this data by age and sex and body mass index. So there's more tables gonna coming down the road. But when we look into the flow data, you usually look for the reserve. Myocardial blood flow reserve global, all the myocardium, all the blood vessel, but also you can look at by each blood vessel, each coronary, LAD, left circumflex, RCA. So I think depending on how you look into it, and also you can create a map, right, which is a polar map. And on this polar map, you can also measure the myocardial blood flow in each category, in each blood vessel, and segment by segment. So it depending on how you project the analysis in your software.
Okay, there is another question. Will radiomics play a role in cardiac PET?
Of course, 100%. I mean, I think if you think a little bit about I think I don't have a slide here, but we have a lot of things that are gonna keep moving with cardiac PET, right, and the tracers, between new tracers and for metabolic and neurological indication, and amyloid. I think cardiac PET really become like not just to image these things, but also how we right characterize really what we see into masses and tumors and uptake, and a lot of cardio oncology indication, right? And not just that, I think it also will affect how we can figure out treatment options, right, in this patient. And I think we know that radiomics has been really increasing recently, and depending on where you are, right, in the country, right, how you use cardio oncology indication and cardiac PET. I think if you have a cardiac patient and you do a cardiac PET CT, that is great. But also if you have the cardio oncology, the cancer patient itself with the cardiac PET with all the application. I know, for example, prostate cancers are very heavy on that. I know also some of the brain tumors as well. But this is an evolving field, I think, and this is why that field with the PET collaboration between nuclear medicine, physicist, radiologist, and then oncologist, hematologist, and the subspecialty who you're looking for. But absolutely, it's evolving, and I think this is where usually it starts, right, with the radiomics and kind of like, yeah, I mean, in a place like in the Middle East or Egypt, I mean, I'm blown minded. Like I think in Africa, I think we have 75 PET scans. Maybe in Egypt we have more than 15, but we don't have the cardiac PET tracers. Maybe we have FDG for the cardio-oncology indication, but I think it's a nice area that we can collaborate and make it happen down the road. So.
Okay, we have another question. I think it's the last. Do you recommend commenting on coronary calcium on low-dose CT based on visual assessment?
I think so. I think it's very useful. If the patient never had a CT before or never had a diagnosis of coronary artery disease, now you are telling that patient you have coronary artery disease. So now you diagnosed him or her with coronary artery disease, and that kind of like add a little bit into the picture of the overall assessment. I would say absolutely yes. And I don't, to put the low dose and analyze it and give you a calcium score can be a little bit challenging at the beginning. So me personally, where I do have a software that can give you the calcium score by numbers, but also that mean I need to transmit the images to the software. The tech have to analyze it. Sometimes now we have AI, right? AI can do that, but also visual is just fine. And I think it's in a busy lab. I think that's totally fine.
Okay, this was the last question. Dr. Hosna?
Dr. Sami, one of our colleagues tried to apply SPECT CT in infective endocarditis. Does PET CT also can do in infection?
100%. I think PET really changed, and I can share you a little bit. I think I do have one or two slides about it. Let me share my screen. And the reason I'm saying that, you guys can see my screen right now, right? So,
Yes.
yeah, I mean, we'll not talk about sarcoid, but like I think this, for example, case, right, with the PET, and this is someone have aortic valve replacement, and he have a little bit of uptake with FDG, and we have new uptake guidelines in this, right? You have with the radio-labeled SPECT CT, and I think that's great, and also now what the value of FDG PET, and I think we'll not go through the analysis and all of that, but I think the most important that trigger ASNIC to, and even all nuclear medicine to learn about this, because the new criteria for endocarditis, the modified Duke criteria that we use, have a cardiac PET into the major criteria. So cardiac PET CT is a major criteria for endocarditis in a cardiac PET. And I think, regardless what are you looking for, vegetation, abscess, aneurysm, fistula, perforation, all the above, and it have good sensitivity, specificity, right, in general for devices, cryoprosthesis, metallic valve, all of these things. Yeah, I think for the native endocarditis, it's not that good, but if you have a metal, if you have an LVAD, if you have a transplant, if you have devices, all the above is really good. And I think we're like, this is algorithm for devices. Yeah, so I think PET CT these days become very crucial in endocarditis, right? And again, right, not a lot of people do that. I think I was talking to my infectious disease department, and they said, "Yeah, we love to use it because sometimes we do echo, we do transesophageal echo, right, and we do." And we don't see infection, and we have positive blood culture, and you do the SPECT, show us some uptake, but also in the PET, it just because in the PET, it's not just you are looking with a high accuracy, but you can image the whole heart and the chest, the whole body, really, and you can see the extra cardiac manifestation. You can see embolic manifestation. You can see things that our imaging and echo, even transesophageal echo, it will not show us. I think endocarditis is a systemic disease, and I think cardiac PET is well equipped to pick this up.
Thank you.
اوكي اتفضلي حضرتك. اوكي this